in your circumstances and survived. However, you have a problem. You start positive. The many who have survived might be a small minority, but many have survived. You have to put it in a positive fashion. In fact, you're not allowed to give bad news that will harm the patient. You're not allowed to cry in the room of somebody who's dying. You want to cry, get out of the room. What's standing there crying? They think I'm dying. You even should be cautious when you start assembling a whole family. Here's a person who's ill. What's wrong? You've got pneumonia. Suddenly the son arrives from Australia, the daughter arrives from Canada, they all stand there with love. No, you think about how you handle this situation. And so going into a hospice where people are not treated is not acceptable. I got a call from a doctor in hospice in England recently, some time ago. The doctor says, I'm standing at the bedside of a patient. The patient has a bleeding problem, and I'm not sure how much blood thinners to give. So I said, well, let's go through the blood, not allowed to do blood tests. That's bad medicine. Absolutely not. The patient will bleed to death because you're not allowed to do blood tests. Not acceptable. And therefore, by the way, the Jewish community in London, I don't know how you have an elderly care home here in Boston. In London, they have an amazing place which is called Jewish Care, which has a hospice. And there you can go to die, or you can go to be treated and come out if you get bad. Not only that, listen to this. They offer what's called respite care. What does that mean? Here's somebody who's been cared for by a family member for long years, and it can be extremely difficult to care for somebody like that. They'll take the patient for 10 days so you can have a vacation. Isn't that amazing? They'll take a person who needs long-term care, and they'll care for them so that the caregiver can go and have a life. Right? So you don't only go there to die. So that's acceptable Jewish. So when it comes to liquids, we need to make sure that basic fluid balance is maintained. Nutrition is much more difficult. Much more difficult to feed people who are very ill. Very often the food's not absorbed. Patients with widespread cancer don't absorb very well. They go into what's called cachexia, which is this wasting stage. By the way, I don't know if you noticed, in the New England Journal of Medicine last month, there's a groundbreaking article on new drug therapy for the wasting and weight loss of cancer. They have now discovered that there are some neuropeptides, right, cytokines, which circulate, which suppress appetite and cause weight loss. And they're on the verge now of medications that block them. Amazing. And the people on those things are actually gaining weight. So the old argument, no, we don't feed people like this because they don't absorb their food. First of all, they do absorb. It's usually the appetite that's the problem. But in Judaism, you have to find a way to nourish people. Now, if the person's dying in a week or two, you don't have to worry about food. Probably they'll aspirate and it might harm them. That's all valid. But if they're dying in 3 months' time and you don't feed them, they'll die of starvation. That's not acceptable. And in many palliative care settings around the world, they don't feed them. I've seen an old Jewish lady begging for a cup of tea. They said, no, the doctor says you can't eat it, it's like a piece of ice. That's just not human. And therefore, we are obliged to not see that people don't die of starvation. How do you nourish people when you can't feed them? It can be very difficult. Demented people, they don't swallow well, they start aspirating, they get pneumonias, can be very, very difficult. So, number one, a little thought and skill. When I ran a geriatric unit in Israel, I did something completely illegal. I had people who were demented, and they were aspirating their food, and turned out that what happened was the highly skilled nurses running the unit were doing what nurses do. They're handing out medications because that's legally required. And my newly arrived Russian immigrants with no medical training were trying to feed the patients, and they weren't doing so well. I got the Russians to hand out the medication. Highly intelligent, most of them were engineers and mathematicians. And I got the nurses to feed the patients. Don't tell anyone, because why not? So you need a little skill. You thicken the food, you get the patient to sit upright, and you can get them eating a long time longer than might have been the case otherwise. When you need to, you might need to insert a feeding tube. If you can get away with a nasogastric tube, that's great. Sometimes you need a feeding enterostomy, a jejunostomy, whatever it is. The problem we face in England, I don't know how you face this here, the usual problem we face is that when we were going to put in a tube while the patient's still eating, the surgeons and anesthetists say, no, they're still eating. As soon as they stop eating, they say, no, they're too sick. How do they handle this in Israel? It's a well-known, well-oiled pathway. They put in a feeding tube while the patient's still eating, and they seal the tube. And they continue feeding by mouth. When the patient gets too ill, then they open the tube, they start using it. But you need the agreement of surgical teams to do that for you. Now in England, we have a few religious geriatricians who are working on this, and so we've made some progress. So that is the question of nutrition. Finally, let me just say one word about what's called a goises. A goises is a unique halachic category which changes all of these rules. Not recognized in conventional medicine, but it's important to know. And that's a person who is dying now. The technical English word is not terminal, but agonal. In other words, they're dying now. They're gasping, gurgling, they cannot clear their secretions. The Talmud says people like that die within hours, maybe 72 hours at the maximum, usually much less than that. And today we're not so good at diagnosing that because we don't let people lie around gurgling and gasping. We clean them, we put them on machines, so it's not so easy to recognize. But when a person is imminently dying like that, then you're not allowed to move them at all. Definitely no feeding, no touching, no moving, nothing. The reason is because that is a very fragile situation, like the last ebb of a candle flame just before it goes out, and the fear is that any perturbation might extinguish the light and kill them. That's killing someone. And therefore, not allowed to move people. According to most opinions, not even internal homeostatic perturbation, not to add a drug or something that's going to perturb the physiology. And therefore, the default position, no nursing observations, you don't move them, the fear is you may kill them. There's some exceptions. Could you hold their hand very gently if they're conscious and they want to? Yes, you probably can. If the hospital's on fire, you can move them gently on the bed. Very often in an ICU situation where you need the place for somebody else who's going to die, you can move them gently without perturbing them. There are circumstances, but the general principle is they don't get treated and they don't get moved because of the fear of extinguishing the life. Perhaps the most notable exception, two. One is you could do something if you think you might save them. So here's this person dying. We've got some radical option that we can do that might kill them but might save them. That's allowed. Again, it's discretionary and it's a whole discussion, but that could be done. And finally, there is an amazing comment by the Ramah, one of our great early authorities, and I'll finish with this, and this is called active Jewish euthanasia. This is as active as it gets. And that is somebody's goises, they're gasping, and they are, chain stokes, breathing, and they're stopping breathing, and there's some external noise that's keeping them alive. So there's a construction going on in the next room, and this person stops breathing. And they're hammering on the wall, then they take another breath. You're allowed to stop the noise. That's Jewish euthanasia. You can stop the external thing that's keeping them alive. In fact, Kabbalistically, that period during which the soul is leaving the body is considered to be spiritually painful, and we don't want to prolong that. And so it's a humane thing to do when the person is dying. Again, we're not treating them, they fulfill all the criteria, and something external is keeping them alive. We stop the external interference with dying. Can't do anything to them to make them die, but you can stop that. There's one extreme opinion that a ventilator in a brain-dead patient may also be an external perturbation on somebody in that, and then you could switch off the machine. Try not to do it, but that could be an exception. So what I've covered for you very briefly today is a general summary of end-of-life criteria. We begin by saying that we do almost anything to save life. We are not allowed to actively end life, even if it might be logical. We don't have the authority to take life. And where we can withhold treatment, and even should, is under these criteria. It's a very general approach. If you'd like a reference, I wrote a book called Dangerous Disease and Dangerous Therapy that has a detailed summary of all of this information. And because it's a complicated book, I suggest that you buy 2 copies, then you'll understand it very well. And I also wrote an article recently in the British Journal of Hospital Medicine, which is a summary for non-Jewish doctors. And the reason you might find that valuable is sometimes non-Jewish doctors think we're being a little extreme or fanatical, or the family's doing things that are not reasonable. And when they read an academic piece written by, cool, calm, connected professional academics, they see we're not being ridiculous. These are the well-known criteria, they're professionally presented, so perhaps if someone emails me, I'm very happy to download that to you, and you're welcome to use it. Any questions before we close?
Thank you very much. You spoke about hospitals and hospices. I come from the nursing home side, and you spoke about drinking and eating